Hello, welcome to the Case for Medicare for All. I am Pete Davis, the chair of the Harvard Law Forum. We've been going for 70 years with this forum. It's really amazing who we have had come through here. We have had Martin Luther King, Malcolm X, Cesar Chavez, JFK, Jimmy Carter, Eleanor Roosevelt, Whoopi Goldberg, Nikita Khrushchev, Betty Friedan, Sally Ride, and joining that crew today is this guy wearing a bandana over here. Timothy Faust, wonderful man. I'd like to thank co-sponsors first. Who here is from the Dems? Anyone from the Dems? Who here is from the National Lawyers Guild? National Lawyers Guild, we got a member over there. And the Progressive Jewish Alliance. Thanks for all the help from the Progressive Jewish Alliance. And I'd like to spotlight a special guest today. Is Adam Gaffney in here? Adam Gaffney? Did he make it in the end? Oh, okay, Adam Gaffney didn't make it, but he was helpful in preparing for this event. Harvard Medical School instructor and activist doctor right here at Harvard. I brought Tim here today because we are focusing the forum this year on the Harvard Law School mission statement, which is to educate leaders who contribute to the advancement of justice and the well-being of society. We've had Matt Stoller here to talk about fighting monopoly power, Ralph Nader to talk about legal education, two Congress people to talk about access to justice. Next week, we have the VP of the SEIU. We have a DSA activist from Chicago, R.L. Stevens. Next in the spring, we have Helen Prejean. And I've even put out a book on this topic, Our Bicentennial Crisis, a call to action for Harvard Law School's mission statement. You can pick up copies over there. And today we have someone here to talk about literal well-being of society, the literal well-being of society. I invited Tim Faust here because I was bothered by a common misunderstanding of the Affordable Care Act. There's been this long-standing project among patriotic Americans to expand health security to everyone in this country, universal health care. And the story goes that every president tried to do it, Truman, Johnson, and Clinton, and then we finally did it in 2010. And we don't really need to do it anymore. Our work here is done. But frankly, as Tim will show you, this isn't true. Just looking honestly at the numbers, we only got half of the job done in 2010. And getting half the job done is amazing. 20 million Americans gained health insurance, but 28 million still lack insurance. Tens of millions who do have insurance are in a situation where it's tied to their employer, and thus they don't have the freedom to fight back against their boss or strike out on their own because of health care. And it's estimated that 150,000 Americans are going to die in the next 5 years due to lack of health insurance. This is not universal health care. We have more work to do, and we are here to learn about one way to do it. Tim Faust is a healthcare expert, Jacobin writer, and the co-host of Heavy Medical, a podcast of health policy and metal album reviews. Tim has been on tour promoting Medicare for All, and we're glad he made a pit stop here at Harvard Law School. Tim Faust.
Howdy, y'all. Does this microphone work? Can y'all hear me pretty good? If you can't, I can just talk louder. I'm pretty loud. Thank y'all for having me. I really appreciate it. I am on a road trip. I'm a member of the Democratic Socialists of America, and I've been traveling around the U.S. talking about single payer, but more broadly, healthcare and healthcare justice. And one of the things I'll talk about, and I know we're doing Q&A afterward, is even though the fight for single payer and the broader fight for health justice is national, healthcare is personal, and healthcare needs are local, right? And so the way healthcare inequity or healthcare injustice manifests in Pittsburgh or Milwaukee or Cleveland or Indianapolis or Boston or Oakland, California is very, very different than how it manifests in other places. So I've been able to go around and get real sweaty talking about single payer and kind of learn and listen to what people are dealing with in their homes. And I've got a lot to say about that. But right now, I want to offer kind of a more broader picture. I want to talk about healthcare and the fight for single payer. Hopefully, y'all are still along for the ride. That is what the event was promised to be. But are y'all interested in talking about healthcare? Is that why y'all are here? Great. Yeah. I want to talk about where we're at now, who it benefits, and what we want instead. I want to talk about why we're told we can't have single payer, and what we got to accept in its place, and why that's horseshit, and what we need to do to realize health justice in America. Does that arc palatable to y'all? Y'all with me on this? Excellent. Let's start by defining what we got now. Let's start by describing the shape and the contours of the enemy. In healthcare, we got a bunch of payers and a bunch of providers. Providers are folks like doctors, nurses, hospitals, physical therapists, drug companies, or the dude behind the counter at Walgreens that sold me Mucinex D about half an hour ago. When someone needs healthcare, the provider provides it. That makes sense. By and large, the costs of receiving healthcare are much, much more than any individual person can afford in a given year. But not a lot of folks need healthcare in a given year. In a given year in the US, half of all medical costs come from 5% of the population. 80% of all medical costs come from 20% of the population. And those populations are fungible, right? Maybe one year you have a premature pregnancy and the next year you don't. One year you get hit by a car or have a heart attack or have a cancer scare, and the next year you don't. And so when these costs hit you, they tend to hit you pretty hard. And so if we made everyone pay for all of their own healthcare costs out of pocket, millions of people would go into crushing poverty. It's not a guess. We know that because out-of-pocket used to be the primary funding mechanism for healthcare costs. And it wasn't until a bunch of socialists and a bunch of unionists in the 1880s insisted that letting people go into lifelong poverty because of medical debt wasn't acceptable that we shifted to a different payer model, the idea of insurance. Now, insurers are companies that receive revenue by charging you monthly premiums. When someone gets sick, insurers spend the money they collect from everybody to pay a portion of those healthcare costs. The sick person is still on the hook for some of it, and then keep a profit for themselves. And so the more revenue an insurer receives from its customers, or realistically, the more subsidy it receives from public money, the wider those costs are spread, and the lower the insurer's per person costs. But if an insurer has too many sick people, right, if just a couple extra people give birth in a given year, or somebody comes down with lupus or multiple sclerosis or other high-cost condition, those per-person costs increase, right? And then the insurer has to increase their premiums to keep pace with paying off those costs and keeping a profit. And then people who can't afford those premiums drop out, except for sick people who really need the insurance to stay on board. So per-person costs keep increasing, and so premiums keep increasing, and more people drop out, and it's built this big, vicious cycle. So thus, an insurer wants as large and as healthy a customer base or a risk pool as possible. Or, in practice, it wants to find ways to kick out sick customers or coerce them into leaving the insurance plan. That's what we mean when we say that we live in a world in which healthcare is a commodity, right? Because future's on your heart and future's on your lungs, and whether or not you need a more expensive HIV/AIDS treatment plan, or whether your Mima's glaucoma gets better or worse before age 65 and she goes on Medicare, are bought and sold for profit by private companies. Now, in this world that we've made, paying for healthcare is very complicated, right? Because payers don't all pay the same rates for the same kinds of healthcare. Some insurers pay more, some insurers pay less, and some don't pay anything at all and pass the bill back to you instead. That sucks. And this fragmented, commodified healthcare model views healthcare as a transaction that only happens when you're insured, instead of a relationship between a person, their body, and their doctors. That's perverted. We have mistaken the profit motives of insurers for healthcare. And over time, we've delegated the responsibility of providing insurance to employers. But that's messed up too, because that results in the status quo of total employer domination, in which your access to things like contraception or hormone therapy or blood transfusions are determined by the whims of your employer. But if you aren't lucky enough to have an employer, if you lack the better skills to get the finite number of better jobs, you're left behind. And so the people who profit from the commodification of our bodies have decided it is acceptable to shackle the well-being of children to whether or not their parents are lucky enough to have gone back in time 40 years, learned to code, and found a benevolent employer. Welcome to the hell world of America 2017. But of course it gets worse. These things always get worse in the beginning of a speech because the costs of healthcare keep increasing. And these costs have been increasing since we first began recording them back in the 1880s, and they increase faster than inflation. Now, part of that's for good reasons, right? More people are living longer with chronic conditions. Cardiac failure, cancer, diabetes aren't the immediate death sentences they were even 2 generations ago. So we spend more money to take care of more folks later in life. That's a pretty good use of money. But costs also increase because hospital CEOs and pharmaceutical companies, close personal friend of the DSA, Martin Shkreli, keep finding ways to charge more and more money for the same services, or racking up fees for unnecessary services, and no private insurer has the negotiating power to stop them. Here's how that shakes out. In the US, the average inpatient procedure costs 40% more than that same inpatient procedure in France. Over a third of antibiotics are unnecessarily prescribed. That's bad for 2 reasons. 1, that's a shit ton of money, and 2, overprescribing antibiotics leads to antibiotic-resistant bacteria, which are an entirely new world of pain and cost. But most egregiously, think of MRIs. You all know what MRIs are? MRIs are just big, fancy machines that print money. In the US, the average MRI procedure costs 5 times more than the exact same machine performing the exact same procedure in Australia. The costs are high because the prices are high. And this whole thing scares the bejesus out of everybody involved, particularly insurers, right? Because insurers are interested in finding ways to mitigate rising costs. Sometimes that means refusing to pay for claims. You've all heard those horror stories. Maybe it happened to you or someone that you love. Before the Affordable Care Act, it often meant that payers would refuse to cover people who were likely to get sick. You all know the phrase pre-existing conditions. But this still wasn't driving costs down. So we all got together, everybody in America in the 1970s, and invented the idea of consumer-driven healthcare. It's the idea that you should make consumers, which is just libertarian for people, pay more for the costs of their own healthcare, right? Because that'll turn them into smart shoppers when people are on the hook for their own costs. And somehow, through the power of the free market or whatever, they'll shop around and not get unnecessary or too expensive care, and they'll find the cheapest ER in town if they get hit by a car, and they'll Yelp their surgeons, and all of this together will drive prices down. But all of this builds an atomized, isolationist, and honestly pretty lonely worldview of what healthcare is, and what healthcare can and should be, right? It treats being sick, or being poor, or being able to get pregnant as a character flaw. And that means if you get hit by a car, or you give birth to a premature baby, or you get rabies, you're on the hook for your own costs because it's your responsibility, right? Because healthcare is a matter of personal accountability. And if that accident, or if that illness, or if that pregnancy forces you into a lifetime of crushing debt or medical bankruptcy so that a hospital, a pharma company, or your insurer can turn a profit, well, tough fucking shit. That's your problem. That's the breaks. Wow. It's a pretty fucking bleak worldview. But here's the thing, it's a big load of horseshit. And you know why it's a big load of horseshit, because people that are forced to pay for healthcare costs they can't afford just don't seek healthcare. I don't mean catastrophic care or care in times of crisis. No, people who don't have access to healthcare or can't afford healthcare costs don't seek primary care. They don't seek preventive care. So they ignore that rash, try not to look at that tumor, or try to think away that chest pain. Because we demand people bear the burden of expensive healthcare costs, they turn their bodies into ticking time bombs until they have a heart attack and die at their jobs and leave their kids behind. Consumer-driven healthcare only serves the people who seek to extract profit from our bodies. And so every single year, labor unions are forced to fight corporations for worse and more expensive insurance instead of being free to organize around better wages, better contracts, or workplace safety. So what do, right? How do you square the rampant increase of healthcare costs with the fact that fundamentally insuring sick people just isn't profitable? Well, if you're the Democrats, you collaborate with the Heritage Foundation to offer us the Affordable Care Act, which is, at its core, the massive subsidization of private industry with public money. The ACA is a bargain. It's a plaintive wail. Please, 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 pretty please, how many billions of dollars do we gotta give you so you stop kicking sick people off their insurance plans? No, the ACA, of course, had its successes, some unquestioned successes. First and foremost among them, the expansion of Medicaid. Medicaid expansion led to a mortality reduction of 5.1% in counties where that was expanded. Among communities of color, that goes up to 11.1%. Now, the reasons for that, we understand. These are people who have had systematic violence enacted upon them, depriving them of their access to health care or the means by which they can afford it. So even the relatively meager expansion of Medicaid does a shit ton real fast to help people with quality of life, quality of care, and accessing care in the first place. That's fucking dope. The ACA also normalized the idea that, I think I'm the first person to say that's fucking dope at Harvard Law Forum. The ACA also normalized the idea that denying someone coverage because of a pre-existing condition is cruel, or at least normalized it among folks that get to be on TV. Everybody else to kind of figure that out intuitively. And the ACA also defined the idea of essential health benefits, which compose a minimum standard for coverage. An insurance plan that covers a nickel of every $10,000 of healthcare costs isn't really insurance to begin with. But at the end of the day, costs keep increasing. Quality of care stagnates for the most vulnerable among us, and 28 million people are still uninsured. The ACA has failed in its pursuit of health justice. So instead, we demand something different, something simpler. We demand a federal, universal, single payer. Single payer is a pretty simple concept, right? It's not having a bunch of different insurers with a bunch of fragmented customer bases, each kind of seeking to pass the buck and avoid taking care of unprofitable sick people. We have one publicly owned, publicly funded insurer with a legislated mandate to cover, in full, all care for all people. Now that phrase, all care for all people, is essential, right? This is a strengthened Medicare for all, not a simple extension of Medicare. You take parts A, B, and D and you merge them. You throw Medicare Part C, which is privatized, grift, throw it into the dustbin of history, and create one program that offers comprehensive coverage, including vision, medical, dental, and reproductive care for all people in America, not just citizens. And you offer that care free at the point of service with no cost share. Here's how it looks in practice. Right now, you want to go to the hospital or you want to call a clinic to schedule an appointment. The first question you're asked, sometimes before your name, is who your insurer is. That makes sense. Providers are afraid of providing services, possibly ones that are expensive to provide, without guarantee of reimbursement. So before we're even considered for care, we must answer on whose dime. We have constructed a huge, dumb octopus. This big brazen brass idol, and this octopus hates us. And it flops around between us and our providers. And this huge dumb octopus forces doctors to spend half their day filling out forms to justify their work to insurers, and forces nurses to spend over a quarter of their time adjudicating claims and seeking authorization for the care they want to give from the insurers in the first place. Under a single-payer system, we shrink that octopus. We drown the octopus. The question of who's paying for it is answered. It's Medicare. We preserve and protect the provider-patient relationship by eliminating the question of how can the patient afford this? Because everybody benefits when accessing care is affordable or even free and easy. Delivering care, right? Being a doctor, being a nurse, being a provider, being a therapist, that shit's hard. Bodies are big bags of goo we barely understand, and making them feel less bad is complicated work. But paying for it isn't. Paying for it is simple. And in fact, we're already paying for it. We're just forced to spend that money really, really stupidly. American public money already pays for 2/3 of all healthcare costs in America. A little less than half of that 2/3, aka 1/3, is direct federal spending on Medicare, Medicaid, and the VA. Other half of that 2/3, aka the second third, is government subsidies to private companies. The remaining third is out-of-pocket costs, an additional tax you pay to businesses, whether in the form of payroll taxes to insurers or premiums you pay to your insurance company, or out-of-pocket costs or deductibles, cost sharing, etc. And so the goal is not necessarily to reduce that spending, although a single-payer program dramatically cuts your out-of-pocket expenses. I think under Sanders' business proposal, average family of 4 making $40,000 goes from spending $5,300 per year in out-of-pocket costs to $470 per year, but to reallocate it to take care of everyone long-term. We know that Medicare negotiates much, much better prices for care because it bargains on behalf of 44 million people nationwide, instead of a few hundo-thundo in a given state or 10,000 in a given city or county. So you scale that idea up. By negotiating on behalf of 300 million people, Medicare can demand fair prices for care and develop the payment models necessary to incentivize good behavior and provide for all providers long-term, treat providers as labor. But even before that happens, we free up all the money associated with administrative costs and profit within the private insurance market. This optimization opens up, in a conservative estimate, $370 billion a year. That's a big fucking chunk of change. So what do we do with all this money that we save? We use it to improve everyone's standard of living. We build primary care clinics in rural areas, the same that have been closed for the past 20 and 30 years. We fund community health centers in poor neighborhoods, and we return the money to the labor that performs the work. Take, for example, y'all know home health aides? Ever have like a sick parent or a sick sibling or a sick kid? You can receive care in a hospital, right? But being inpatient costs $10,000 a day, and your dog doesn't live in the hospital. You can also receive a lower clinical standard of care at home, injections, physical therapy, some kinds of hospital services at home. It's a whole lot cheaper. The average home health visit is paid or is billed at $152 per visit, and it's much more humane because you're at home or your computer lives. So everybody benefits, right? More humane, cheaper care. Well, everybody benefits except for home health aides themselves. There'll be 1.2 million of them by the year 2020. And for that $153 they're billed at, they are paid an average of $11 an hour. So we can allocate this money to do what the private market won't, which is pay fair wages for essential care that helps everyone. Right now, your private insurer only bears the costs of you receiving care right now, right? Because you're likely to change insurers in the future and eventually go on Medicare. They don't actually feel pressure to provide you with care that keeps you healthy in the distant or even near-term future. Instead, we all do, right? Because we all suffer when our friends and family get sick, and our public money is allocated to care for folks in times of crisis or catastrophe. Insurers have this fear that if you make getting healthcare cheap or even free to people that are using it, people might use more of it. And that's really hard to make a profit off of. So it makes perfect sense that the same actor who suffers when people don't get care, which is all of us, united, represented by our federal government, should also be the actor that pays for that care in the first place. Because once the federal actor bears the costs of providing care and the risks and costs of not providing care, it can finally be a tool for realizing health justice. If your people are getting sick and dying because they don't have a place to live, or the places they live are unsafe, they're full of pollution, they're full of mold, they're flammable. I'm thinking of Ghost Ship in Oakland or the Grenfell Towers in the UK. Then housing is healthcare. And you are forced to build subsidized, safe housing to bring healthcare costs down. If people are getting sick and dying because they don't have access to healthy food to eat, and so they're getting diabetes and comorbidities like cardiac failure, then food is healthcare. And you provide people with affordable or free food options and the time, space, and materials with which to prepare it to bring healthcare costs down. If your people are getting sick and dying because they don't have access to needle exchange programs, therapy, or counseling, then rehabilitation is healthcare. And you build full-cycle addiction treatment programs. Instead of our current end-of-life palliative care bullshit, you offer the full safety structure, the full social structure required to break free from addiction, or perhaps not choose it in the first place to bring healthcare costs down. Because single payer is only the tool. Health justice is the actual goal. And when we fight for health justice, we all fight side by side, because economic justice is health justice. Environmental justice is health justice. Reproductive justice is health justice. And justice for Black lives, justice for trans lives, justice for the lives of immigrants, and the well-being of all people, regardless of age, gender, race, or creed, that's health justice. We have inherited a world in which your permission to receive healthcare, capital's allowance that you can be safe in your own body, is dependent upon how much an insurer can extract a profit from you. When people are in need, we waste time, effort, and money means testing, separating the worthy from the unworthy among those who need help, and then stigmatizing them instead of guaranteeing the basic decency of health equity. And for systematically marginalized people, sick people, homeless people, people struggling with addiction, people with disabilities, poor people, pregnant people, trans people, women, and people of color, when there is no way for the medical industrial complex to find value in their bodies, then there's always the private prison system ready to receive them for profit. My friends, single payer is moral. Single payer is necessary. And single payer is achievable. Solidarity now, solidarity forever. I've got some... Y'all are law students, and that's kind of part of my general speech I give the people I want to canvass with me. But I put some notes together on what y'all can do, and what it looks like to be a law student in the fight for health justice. Y'all down with that? A little bit less shabby. I want to speak very, very briefly on what y'all can do as law students and as lawyers to help realize the vision of health justice. We are told this is the way things are, and that in fact this is the way things have to be, right? We're told that universal health care is a pipe dream, and that capitalist, corporatist domination of our bodies and of our health is natural, normal, inescapable, and irreversible. That single payer will never ever happen in America, and that's just the Democrats speaking. But the myopia inspired by the profit model has limited our conception of health to what happens within a clinic. But we know that's not the case, right? Health is a relationship between a person and their environment. And over time, we have kind of codified the civil and legal protections which permit a person to enjoy their health and the freedom from feeling condemned in their own body. But we don't always permit people access to these protections, right? If you're a rich person, you have the means or the ability to delegate somebody to find the legal protections to which you are entitled. But if you're poor, or you work 60 hours a week, or you don't speak English, or you don't read very well, you don't know where to find the fucking forms to get the rights to which you're entitled. And so a more just vision of the world depends on us delivering to the people of America the rights to which they are entitled. How many of y'all are familiar with the idea of medical legal partnerships? Anybody here? Hell yeah, a couple of y'all. These things fucking kick ass. It's not all y'all, because if it were all y'all, I'd have a lot of redundant things to say. A medical legal partnership is a model of primary health that was developed, I think, primarily first in Boston, so not too far from here. It understands that there are these civil and legal protections which affect a person's health. And if you want to treat a person long-term, you got to take care of the whole person, which is not just the person that appears in the clinic. Here's an example. There's a medical legal partnership in Boston, and someone shows up with a kid, a 3-year-old kid. And it's a Medicaid clinic, it's a federally qualified health center, so it's serving primarily a low-income population. And the person says, hey, I've got this kid is 3 years old, this kid is my kid, this kid has real bad asthma. This asthma is really fucking bad, and we don't know what to do. There's a social worker who serves as the intake. The social worker intakes the patient, intakes the kid, says, okay, you need clinical help. Here's the clinic, here is a nurse practitioner or a doctor, physician, let's take care of you. That's good. But at the same time, that social worker realizes, well, wait a second, like often things like asthma are caused by home conditions. So what's your home like? And the person said, this is a real example, well, we live in a slum. Like, we are poor, we have a slumlord. Our home is full of pollution, our house is full of mold. Social worker says, well, 1, that's fucked up. 2, that's probably related to the asthma. And 3, you have a legal protection against that. Luckily, we happen to have a lawyer who was in the same facility. So let's walk over there and bring the lawyer. And the lawyer, or I think the 2L, offers a form letter threatening to sue the person's landlord if they don't bring the apartment back up to code, and offers to follow up within a couple of weeks. That is a way that you understand the whole person is involved and the legal protections are involved in the provision of health and the idea of health equity. So those are fucking cool. But also, sometimes these protections fail, or sometimes we permit them through inaction or malice to fail. Let me give you all an example of where things go wrong. I recently had the pleasure of hanging out in Indianapolis with members of the DSA. They're a pretty fun crew. I'd never really been to Indy, and I had a good time there. But I heard about the story of Scott County. Y'all familiar with Scott County, Indiana? It's in southwest Indiana. It is one of the few places in America where HIV/AIDS has increased year over year to the form of like an epidemic. There's a new epidemic of HIV/AIDS on the entire population in Scott County. And so I want to understand, why does this happen? Like, how does this happen? So I talked to a really earnest, like 24-year-old guidance counselor, I forget his name, who kind of helped walk me through, he worked in Scott County, why and how this had been permitted to happen. A couple of things happened at once. 1, Eli Lilly, the pharma company in the region who produced the opioid, the preferred opioid for people that struggle with addiction in Scott County, wanted to maintain their patent. And just like what Purdue did with MS-Contin and OxyContin in the 90s, Eli Lilly wanted to produce a new and improved form of their opioid to preserve their patent. So what they did is they made their opioid abuse resistant, which means you can't crush it anymore and store it. Which means if you want to abuse it, you got to dissolve it in water and inject it. People don't stop abusing drugs when they're hard to use. They just find new ones, or they turn to heroin, or they turn to fentanyl. So that's happening. At the same time, then Governor Mike Pence, perhaps you're familiar with him, decides to shut down all the state needle exchange programs because only criminals use needles, right? This is the war on drugs. If you are both sick and poor, you go to jail. So he shuts down the needle exchange programs. And at the same time, the state board, the state ledge, shuts down a bunch of primary health care centers, community health care centers, Medicaid clinics, and Planned Parenthood in the state. So now if you are a person struggling with addiction, you have to change to an injectable drug, there are no clean needles available, and there is nowhere to get care. So you know what happens next. HIV/AIDS increases, hepatitis increases, all these kinds of preventable conditions that result from not guaranteeing people health equity or treating them like people spread. But that's not where the story ends, because these people have families. They are part of a broader system. And Indiana has a robust school choice school voucher program. So in Scott County, you've got some of the people are dealing with addiction, and they're going to jail because, again, if you are poor, you are sick, you go to jail. But some people don't. Some people have means. Some people have wealth. And they don't want their kids to go to school with other kids whose families compose the walking dead of the state, so they send them out of county, and they send their property tax out of county along with them. So now you've got a school district with more and more population of kids that are dealing with horrible epidemic issues at home, or opiate issues at home, or families or parents that are in the system, and less money with which to provide for them, right? And so this 24-year-old kid, this guidance counselor, could point at kids from a mile away and say, that kid's dealing with some shit. This kid has mental health problems because the foundation of their life has been pulled up from underneath them. But we can't do shit about it. We gotta gut our school breakfast program. We need to shut down our mental health programs. And so what happened? A year-over-year increase in child suicides. This is the consequence of health injustice. This is the consequence of the erosion of civil and legal protections of health equity for all people, including the most vulnerable among us. Now, this need not be the better world we build. And in fact, the better world demands many hands. If you do not articulate your own position and your own vision of a better world, someone else will claim to articulate it for you. So if you choose to take up this fight, and I really hope that you do, it will be my honor and my privilege to stand beside you. And I am so, so proud to stand beside you today. Solidarity now, solidarity forever, solidarity. Oh, thank you.
So Steve, you're voting for Timothy Faust. I'm going to start with 2 questions, and then we're going to open it up to everyone. I'm going to shout since this mic isn't working. So question 1 is a dumb question. But,
No dumb questions.
How are you going to pay for it?
We're already paying for it. Dumb question. I just fucking hypocrited myself. There's this idea that single payer is an added increase in cost. It's not. At its very core, if you keep the financing mechanisms the exact same, single payer just preserves our current level of expenditures. We're spending $3.2 trillion per year right now under the current model of multi-payer healthcare. If nothing changes, that'll go up to $4.7 trillion by the year 2027. Under a single payer program, all projections, even conservative ones, see costs being flat at 3.2 or 3.3 trillion over a year. We can't afford not to fund this. And in fact, this is a relatively benign transformation. The idea of just take the money we're spreading out among a bunch of independent private payers and aggregate it under a federal single payer isn't that radical. We're just shifting a column in Excel from who the payer is to who the payer is. Not that fucking complex. We're already spending all this money, might as well spend it efficiently, right? That's all that single payer offers. Is that if we force the federal actor to be responsible for all the money that is spent, it is then forced to reconcile what it spends money on and what it does not spend money on, and the entire life cycle of health and how health happens. Right? We know, we understand, nobody's fucking surprised by the idea that stage 4 cervical cancer costs a whole lot more to treat than stage 0 cervical cancer, right? Stage 4 cervical cancer costs, I think, $4,000 to $6,000 to treat. Stage 4 costs $170,000 plus to treat. Nobody's fucking surprised. That makes sense. But the multi-payer model has been absolutely silent on how do you fund stage 0 training? How do you stage 0 screening? How do you bring people in to get care at the early stage? How do you provide affordable local care to people when they most need it or when they most benefit from it? Multi-payer model has no answer for that. And it has refused to, I think, score this question in the eye. We cannot afford to let this question persist because people are dying from it. Single payer forces the federal government to reckon with this question without changing our, it doesn't increase costs. Also, the correct answer is you tax the rich. But even absent that, even absent radical ideas like taxing offshore accounts or a more progressive tax platform, the money's already there. We're already spending it. We might as well spend it all.
Slightly harder question, then I'm going to open it up for others. Some people have challenged, even people who care about this cause, challenge single payer in the sense that if the federal government has its hands in all of healthcare, then if the federal government is at some point taken over by theocrats, which is not that distant of an idea, suddenly you start saying, oh, there has to be a prayer before every this, or we're not going to cover this, or this, that, or the other. Whereas if you have a multiplayer plan, you can have progressive plans, even if it's taken by others. How do you respond to that?
Yeah, they've done a really good job with that so far. That's a real concern. And the problem is relatively simple. You put it in the legislation. Look, think of CHIP, for example. Rest in peace, CHIP. One of the reasons why CHIP was permitted to be used as a fucking football to harm the most vulnerable people in America, because it was a function of discretionary spending, right? When you permit gaps which can be determined by an executive or legislative body, you permit the possibility for a bad actor to get involved and spike it around. A couple of things with that. One, you must put in the legislation pretty simple and immutable guidelines. All care for all people. Comprehensive care. Free at the point of service for all people. All care must be covered. These kinds of things that leave no room for discretion among a bad actor. Secondly, right now, we already live in this world. We already live in the world in which there's such a thing as a progressive insurance company. There's insurance companies that want more rich people and healthy people, and insurance companies that try to rack up risk adjustment costs by having more sick people but then denying them care. Right now, we have no accountability over the current multi-payer model. You can't fucking vote out Athena. By making this a federal program, you have the authority to scare your legislator into fighting for the candidate you need to have. It demands a popular movement. One of the reasons that I like Organize for Single Payer is that in the 1880s, it was unions that scared the shit out of von Bismarck and demanded socialized funding of employer-sponsored insurance. After World War II, it was unions once again that demanded or threaten general strikes unless states built single-payer or universal healthcare programs throughout Europe. But now we live in a world in which unions have been deprived that ability, right? If you go on strike, the first thing you lose is your healthcare. Unions have lost a whole lot of ability to organize and fight. And so the only thing that can build this movement or that can demand this change is a mass popular movement. And I believe that if that movement exists, which demands single payer, that movement also exists to demand accountability from electeds to preserve that program. But the simplest answer is don't fucking permit room for discretion in how the bill is written and how the bill is passed.
Let's open it up for questions. Anyone out there? You right there. Yeah.
Okay. I'm curious to hear more about like what organizing you do on the ground. Like I know DSA is putting this as like a primary focal point of their platform, and Arnold Stevens will probably talk about that next week to some extent. But from like the organizing that you've been a part of, I'm interested in what's surprising about folks' reactions to single payer. So I know from like working with physicians for a national health plan.
Yeah, hell yeah, they rule.
In upstate New York, like folks who are elderly Republicans in upstate New York are all about single payer.
Because they've got a taste of it, right? They've got a taste of the watered down thing of Medicare that we have now. So you have two questions. One is kind of what's DSA's organizational process, and one is like what are the things that are surprising. We'll answer those in that. One, DSA is pushing for canvassing, deep canvassing, as a model for building a popular movement. Right now, the idea of the canvas has kind of been perverted by mainstream parties into this weird, Taylorized Frankenstein, or more pedantically, Frankenstein's monster, of like, knock on the door with a clipboard and say, please sign this thing for this bill, and then I will leave you alone. And the conversation, the connection ends there. That's not how you build solidarity. That's how you build a fucking database. That's stupid. If you want to build a popular movement, you must build a shared vision of a better world with people around you, people that don't look like it, people that are afraid of it. And so DSA has chosen canvassing as the tool with which locals build towards goals that are in like the broader stretch towards health justice, right? The idea is that we demand health justice. We believe federal single payer is the tool which helps us realize it, but we understand that like on the local level, like you can't really organize for federal single payer, but you can organize for things which make a federal single payer more likely, and which more importantly provide material relief and material comfort to people now. So here's some examples of things that I've seen. In New York City, the Social Feminist Working Group is organizing, within the context of canvassing for health justice, direct Medicaid and ACA enrollment, because Medicaid enrollment is super, super low. In New York, after all the hospital aggregations through the past 20 years, and even more so following Hurricane Sandy, fewer people have access to Medicaid enrollment, which mostly happens in a hospital facility or in a clinic facility. In Indianapolis, they're canvassing for transport. They understand that people, particularly in the rural parts of the county, don't have fucking access to buses. And so if they need dialysis or if they're on Medicaid, they can't even get to the clinic to get care. So they're putting together a transportation program to try to get people to disability aid service. Because if you're on Medicaid and you missed an appointment, you're off the list for getting a replacement or even more comprehensive therapy. In Vermont, where Act 48 was gutted by the snake of a governor, Act 48 being the state single payer program, they're canvassing for a primary care for all people in Vermont program. That's not enough, but it certainly does a whole lot real soon to help people. In Chicago, they are putting together a Grover Norquist style, like single payer only pledge for local electeds, as also demanding funding, Medicaid grant funding for the trauma care centers that have closed throughout the city over the past decade. What else? A whole bunch of, like, all these things are pretty different because healthcare needs are pretty different in different places. And I think all these things fit, right? Because this is a long fight. We're going to be pretty specific in optimism, right? Like, whether it's Bernie's bill or Conyers' bill, or hopefully a bill yet to be written, because both of those bills are not enough for what I want. Like, when it comes time to discuss them, just like the fucking worst ghouls of capitalism, the most like flapping jawled lapdogs of American capital will come to attack them. And so we must build the defense and, in fact, the offense now. We must be prepared to fight. The only way you do that is by building a popular movement. And the only way you build a popular movement is by offering material aid now, organizing for a better vision, or a shared vision of a better world, and offering like an incremental step that makes the end goal more likely. As far as things that I've seen that have been pretty optimistic, I have one anecdote, actually, from upstate New York. I was talking to some canvassers at the DSA, either Albany or Albany. One's in Texas, one's in New York, and I keep fucking it up. And both of them get mad at me when I say it wrong. So let's say DSA Troy or DSA Schenectady. They have started a canvassing program, the New York Health Act. That's cool. That's cool thing to canvass on. So I spoke with a canvasser who's an adjunct professor at RPI, also happens to be a person of color. And so he and his canvassing buddy went out and canvassed a bunch of trailer parks, I think west of Albany. And so they're knocking on doors, talking to people, saying, well, hey, like, what are your fears in healthcare? How are you, like, receiving healthcare now? Like, is it hurting you? Who's fucking you over? What do you want instead? This guy knocks on the door, and the guy opens up, and he's got big fucking SS tattoos in his neck. Holy shit. This canvasser, who has more courage than I will ever have, just keeps on going with it. Opens the conversation. I'm here with DSA. I'm here to talk about single payer. Let's talk about your healthcare needs. And the guy fucking goes for it. He's like, well, I'm terrified. I've got a bad lung, and I've got a bad leg, and I've got a daughter. And if something happens to me, I can't afford to get care, and I'll leave her behind. This guy fucking radicalized a neo-Nazi. I'm not saying that's DSA's goal, to radicalize neo-Nazis. Like, a lot of these divisions that exist between us are kind of reduced or even eliminated when we discuss a broader idea of a world that helps all of us all together. If that guy can canvass a neo-Nazi, anybody can canvass anybody, and the popular movement is inevitable when we make it inevitable. And I've heard stories like that up and down the plane. People that are otherwise terrible. Like, people operate out of a sense of fear of loss, right? I'm afraid of people. Like, means testing tells us that it is better for a worthy person to be denied care than an unworthy person to receive it. This creates cracks which are then widened and exploited to make people afraid of each other. Means testing is basically codified permission to explore all the kinds of fucked up bigotries you have in a political program. Offering a single platform, a single program for all people, I think eliminates a lot of that harm and lets folks see each other as people. And our reactions we've seen across the board have been pretty hard. I mean, Medicare for All is fucking polling at 64%. This is not a fringe position. It is just fringe among people that get to be on TV. Did that answer your question? Cool. Oh shit, I'm so sorry. I'm talking.
So obviously the single payer can take a bunch of different forms. And you mentioned like free at the point of service being sort of one of the pillars. I was wondering if you could go into why that is so important, and also maybe what are some of the other pillars as you see it, like the most important things.
Right. Free at the point of service is essential because when people are forced to pay for healthcare, they don't seek healthcare. And we understand when people don't seek healthcare, it's primary preventive care, which is the first things to go. So by making people pay the $100, $200 to get screened for stage 0 cancer and get it treated, we are then asking them to wait until things are real, real bad and spend a ton of money that they can't afford down the road. There's this, the RAND, that's a scary term, the RAND health insurance experiment in the 70s found that when people were forced to pay for like cost during the point of service, rich folks were fine because they could afford it. The folks that couldn't afford those co-pays just like did not engage with care at all until a catastrophe happened. This is actually a cost reduction measure by making it free for people to seek care. There is a fear of the moral hazard, which is the fear that if people go out and seek care, they might seek more of it. But I think that is, one, mostly spurious, and two, entirely offset by taking care of, like, instead of letting costs be aggregated by 5% of people who have been forced to get only catastrophic or like very, very late stage care, by spreading out that distribution of costs and more people who are getting earlier care, which then gives us like a ton of things we can change. Other pillars that I think the DSA includes: free at the point of service, comprehensive coverage, that is all care is included for all people, not just U.S. citizens. Once you make that discretionary, you fuck over a lot of people. No cost sharing, which is different than free at the point of service, like no like deductibles, no things that you have to rack up against. And then also a fair transition jobs program. Insurance labor is labor. I myself work and have worked in insurance, although they don't know I'm here. That's the camera. But like insurance labor is labor. Providers are labor. Treat labor as labor. It is estimated by People's Policy Project that there are about like 100 to 200,000 people whose jobs might be eliminated through a single payer program. But luckily, like single payer also creates a bunch of jobs that then need to be filled, right? And so we must build a fair transition model, modeled after what unions did in oil and gas 20, 30 years ago, to provide them with the tools, resources, training, and any kind of expense to like take care of them down the road. Honestly, like Bernie's bill aggregates 1% of the health budget to fair transition, which is a shit ton of money for not very many people. So like we're pretty good on that front. But like actually, I want to talk on that for a second. Like we understand that like the provision of a more just healthcare state demands hiring a bunch of people to do essential work. Y'all know Matthew Lesko? Matthew Lesko was a dude in public access TV in the 90s. He wore like a big Riddler suit. There's free money from the government. The government owes you free money. Like a couple of another guy I'm talking about is this fucking dude whose whole shtick was like, the government owes you money, and I am so excited to find the ways you get the money that you deserve. That's the model for primary care under a more just health state, right? Like the social worker who finds somebody the legal protections for housing is a version of a Matthew Leska, someone who is so excited to find for you all the protections and all the health services to which you are afforded. And if you have the skill set to adjudicate a claim or to deny someone coverage, you have the exact same skill set required to find someone more kinds of care or to find more kinds of like health justice a person is entitled to. So I believe a single payer forces us, it's not by itself, like as a parallel goal, forces us to reckon with that we must hire patient advocates, we must hire social workers. The only way you overcome like massive systemic violence in the provision of care, basically the racist provision of care, a study in 2012 found that cardiologists offered less good cardiac care to black patients regardless of their ability to pay for it or how sick they were. And we know the only way to get around that is to hire more fucking patient advocates, social workers, who look more like the communities that they serve, who push against doctors to provide the best care possible for the patients they represent. These are the kinds of jobs we need to have if we want to bring long-term costs down. And so understanding that like there is a labor component to this, that we must like advocate for it proactively, gives me pretty fucking amped. Does that answer your question?
Yeah.
Cool.
Before we close out, I believe both co-hosts of HEAVYxMEDICAL are in the room.
Yeah, hell yeah.
And a former Harvard Law student, right?
Yeah.
You're fighting Kelly Joe Hobby running for. Is there any plug for HEAVYxMEDICAL?
I think that we should be coming up with a new episode within the coming week. I know we were going to talk about the opioid crisis. What else were we going to talk about?
Shit ton. The social work for prenatal care
Yeah.
in Western St. Louis.
Yeah.
The idea that if you work at an NGO and you want to work in prisoners' health rights or prisoner rights, no fucking NGO will touch it.
Yeah.
Which I think perpetuates the broader opioid crisis because that's care for people that are in jail who don't deserve any kind of legal representation. So we got that.
Yeah.
We
And
have-
we have like 4 episodes that are, I don't know.
Fetal protection
really
laws.
good. Some stuff on HIV and insurance discrimination. Stuff that I learned actually at CHILPI, the Center for Health Law and Policy Innovation. I highly recommend that clinic. I also really recommend the Legal Services Center. And also, like, if you have any questions about like doing public interest law or justice law stuff, you should email me. It's just kjhopkin@gmail.com.
And she's really good at responding to emails.
I'm very bad at responding to emails, but I will respond to you if you're talking about health law stuff. So, yeah.
An alumni that belies the fact that there's nothing you can do after we get out of here.
Oh yeah, no, fuck that.
Yeah.
Like,
There's so
do
much we
public
can
interest
do.
law. Don't go into corporate law. You will thank me later.
On that note, any final words to Harvard Law students on?
Thank you for having me. I'm sorry I swore so much, and I love you. Have a nice day.
Thank you.